Hey everyone. So today we're going to cover two simple strategies to help you improve femoral internal rotation, or at least to guide your sequencing of strategies that work towards restoring femoral internal rotation. And we're going to share two kinematic concepts with you that we teach in our courses that help us structure our loading strategies when we're going about restoring any kind of restricted movements, restricted motion. Okay, because when we're trying to restore variability into the system, we need to have some kind of framework that guides the implementation of strategies to restore that variability. Because in this case, it's not a simple situation where we just need to drive the femur into more internal rotation. Sometimes clients have pain, sometimes clients have restrictions for prolonged periods, and sometimes it's a case of unlearning certain strategies that might be more protective in nature or might be more provocative in nature as well before we actually learn new strategies. Okay, so all those variables will come into play to help guide our loading strategies. So this is a concept of directly facilitating motion, so directly facilitating femoral internal rotation in this case, and then indirectly facilitating femoral internal rotation in this case by biasing the femur towards internal rotation and then challenging the dynamic movement of a neighboring complex or a distant complex, joint complex, to challenge the maintenance of that internal rotation, which is going to be the ankle in this case. We're going to use the ankle, the dynamic motion of the ankle, to challenge the maintenance of femoral internal rotation. Okay, so first we're going to look at the direct strategy. Okay, so the direct strategy is mainly looking at restoring the direct segmental rotational capacity of that femur. Oftentimes you see people talking about strategies to restore femoral internal rotation, and it doesn't actually look like the femur is in an internally rotated position, but they're biasing neighboring segments in different directions to restore relative femoral internal rotation. And then they're actually producing force more so through the sagittal plane, so through hip extension, flexion, knee extension, flexion, and mainly kind of hip and knee dominant strategies. Okay, but sometimes we actually need to restore the direct segmental capacity to rotate the femur and then build load in this rotational direction. Okay, so we're going to use a very commonly used strategy here that you'll see in a side-sitting position. The right lower limb is a target limb here. We have the knee flex at 90, the opposing knee flex at 90 as well. And we like to start in a propped up position on the hands where the trunk is a little bit more vertically orientated, because what that does is it actually gives our pelvis the capacity to posteriorly tilt and extend relative to the femur here, which actually brings the femur into a little bit more flexion. Okay, when we're working towards restoring femoral internal rotation, we like to do it from a place of flexion and then work towards extension, because typically when we're in more of a flexed position, we have a wider scope of options to rotate that femur. Whereas when we go back into more extension, we typically have a limited scope of options to rotate that femur. Okay, so propped up in the hands. And the goal is to be able to rotate the trunk and the pelvis as a single unit, if you like, to the right in this case, okay, where the actual femur is rotating to the left, because an internal rotation of the femur is a rotation towards the midline, which will be the left in this case. Okay, so pelvis rotating to the right, femur rotating to the left. With this strategy here, you're looking at more from a directional standpoint. You could say that again, the femur is again biased towards internal rotation, pelvis is biased towards external rotation, because an external rotation is a rotation away from the midline. But again, just think of it as pelvis rotating right, femur rotating left. And one of the key things with this strategy here, when we're trying to restore that direct femoral internal rotation, is that if we keep this opposing limb on the ground, that's almost pulling the pelvis to the left as well. It's almost dragging the pelvis or limiting the capacity of the pelvis to rotate in the opposing direction. Because when we turn the right femur to the left femur to the left, that's dragging the pelvis with it. So if I keep that femur on the ground here, that's going to limit my capacity to turn the pelvis to the right, which is what I want to do to get more of a direct rotational dissociation between pelvis and femur, if I wanted to really try and expand that kinematic space between femur and pelvis. Okay, so the way we're going to achieve this is by bringing the opposing femur into internal rotation as well, bringing it towards the midline as well, which will help me rotate the pelvis away from that left-hand side towards the right. Okay. And this is going to get us a little bit more relative internal rotation at that right femur. And then we're building pressure down into the inside edge of the foot. We're not going to talk about, the force production levels of intensity here. Again, this will be based on the client. Typically, we like to start with 30 to 40% of the client's maximal voluntary contraction and hold for about 30 seconds, and then continue to expand that space within the femur. Okay. But we may have to kind of gradually bring this opposing femur into more and more internal rotation. Okay. And then as we progress even further, we can actually come down onto the elbows, which will allow us to get the trunk and the femur into a little bit more of a kind of a parallel relationship, if you like, which won't allow the pelvis to posteriorly tilt as much. Okay. So like I said, we like to keep that femur in a place of flexion before we move back into extension, and starting propped up in the hands and then moving onto the elbows is a nice way to organize that. So the direct approach, again, quite simple here. We're trying to directly facilitate femoral internal rotation. We're trying to expand the kinematic space, which is just the relationship of bony segments. Okay, and obviously this requires a certain behavior on a contractile muscular level as well. The muscles need to be able to behave in a certain manner to allow for that kinematic representation to occur. We're improving dissociation capacity in the transverse plane here, where we're letting the pelvis rotate to the right, femur rotate to the left. Okay, and we're building directional rotational force production. So we're actually building force here into external rotation when we're driving load down to the foot. We can also build it into the opposing direction as well. But the key thing there is that we're actually producing force into rotation, not necessarily into the frontal plane or into the sagittal plane. Okay. But now let's work into the more indirect strategy. So if you had a client on the table and you measured internal rotation, you found that it was very limited, they didn't have the range of motion necessary, this indirect strategy would necessarily be the first one that you would try, unless the client has an adaptable behavior around the pelvis. So sometimes you'll have a client where it's very easy to actually restore a little bit of femoral internal rotation, but then once you challenge them with any kind of load, any kind of stress, they typically lose it very, very quickly. Okay, and that's more of a strategy type situation where they're not able to maintain that internal rotation capacity as we add stress to the system. Okay, whereas if it's more of a space issue, if it's more of a range of motion issue, then we may have to use a strategy like this to restore that space before we challenge the strategy that the client's actually using. Okay. So again, this is just one of many examples that we typically use, one of many strategies that we use with clients. So again, we'll get them into and again, these are ground-based strategies. Lots of strategies that we can also use in a standing position as well. But just to keep it simple, 2 ground-based strategies first. We're in this kind of supine bridge position with the foot elevated on a femur or on a foam roller, and the foam roller elevated on a block. Okay, this just gives us the ankle a bit more room to drop into dorsiflexion, plantar flexion. But the key thing here is that we're building force through the forefoot. Okay, keeping the ankle in more of a mid-range position. We're scooping the pelvis up. So we're trying to actually bias that pelvis towards extension, posterior pelvic tilt, because when we're trying to restore femoral internal rotation, we want the pelvis to express a little bit more extension to allow the femur to internally rotate relative to that extended pelvis. We posted some articles before in the past about how when the pelvis extends, it will naturally couple with the femoral external rotation in the same direction. And so if we wanted to really get honest internal rotation at the femur, we want to try and do that relative to an extended pelvis. Whereas if we're doing it relative to a flex pelvis, this wouldn't really express that dissociation, because typically when we flex the pelvis, it will drag the femur into more internal rotation, but it wouldn't necessarily be honest, true femoral internal rotation. It would just be an internal rotation in space. Okay, so key thing here, building pressure, scooping the pelvis up. But as you can see right there, we're bringing the knee across. So that knee is coming across the midline. So if you imagine your head is, medial to the limb in that scenario. So you're looking down and you're looking kind of around this area here. You want to see that knee come across, so it's almost in line with your nose or slightly to the other side of your nose. So again, it's biasing that adduction, internal rotation behavior. Okay, it's bringing the tibia along with it. It's bringing the foot segment along with it. So the whole femur tibia foot segment is biasing more internal rotation relative to an extended pelvis. We're trying not to let that pelvis rotate in the same direction. Then what we're doing is we're just maintaining that position of the knee, the position of the femur, and we're just perturbing the ankle. Okay. Now, what we mean by perturbing the ankle is we're not trying to improve any capacities at the ankle here. We're just trying to challenge the dynamic ankle motion and see, can the client maintain that femoral internal rotation? So we're trying to challenge their capacity to hold on to that strategy. Just like if you're challenging someone's balance, and you would get them into a position that challenges their balance against gravity, and you might perturb them with maybe a kind of a hand push to the trunk and see, can they maintain that? So you're challenging the strategies they're using to maintain their posture, their position against gravity. It's the same concept here, but you're changing the strategy that the client is using. Because oftentimes you'll see in clients that have either poor femoral internal rotation, or they just can't hold on to it during strategies, because you see that knee begin to deviate out laterally to the right in this scenario. Okay, where they're losing that internal rotation of the femur. We see it very often with clients. And what you're also doing here is you're challenging the attentional focus of the nervous system. So now we don't really want the nervous system, hyper focusing on what the femur and the pelvis is doing. Now we want to shift a little bit of attention distally into the foot and the ankle, which can be quite threatening for a client that has had so much attention and focus placed through the hip and the kind of proximal region for so long, especially if they've been dealing with pain and movement limitation around that area. Now we're asking them to shift that attention distally, which can be a big progression when it comes to our loading strategies and our loading progressions. So again, we can't underestimate the importance of kind of understanding, how a change or a shift in attentional focus will challenge a certain capacity that the client's using. So hopefully you can see the difference between those two strategies. One's directly challenging the internal rotation capacity. The other is biasing the femur towards internal rotation and then challenging a distal segment dynamically and seeing, can we maintain that internal rotation? And this kinematic concept has massive, at least for us, implications across the entire movement system. We use this concept very often to challenge the strategies that the client is using, particularly if they've been using a certain strategy, an unhelpful strategy potentially for a long period of time, or they're trying to improve range of motion but not holding on to it, even after trying to directly change that local space, that local segment behavior. We may need to challenge the strategies the client's using. So two kind of different strategies there, two different purposes, but both important as part of a rehab plan or a rehab process to help restore femoral internal rotation.